Hey, good afternoon, everyone. My name is Gage Woolley. It's really great to see some of you again. I know some of you were in some of the other webinars that we had earlier this week. Both, actually, we just had two yesterday. We have one today and then one more tomorrow still to follow. We're really happy to have Jan Stockton on with us today to talk about ending the HIV epidemic. I think this is a really just important topic, and a lot of different folks were asking for it. So we're really excited to have one of the experts in the field here. Jan's actually one of our alumni, and really excited to just have her because she's so involved in this field and actually knows a lot about it. So Dr. Stockton, just as a quick bio, is certified as a clinical nurse specialist in an adult health nursing by the American Nurses Credentialing Center, as an advanced AIDS certified RN by the HIV AIDS Nursing Certification Board. She also has clinical experience in HIV home care, hospice, clinical trials, ambulatory care, and HIV PrEP, in addition to giving multiple presentations and publications on HIV prevention, treatment, and care. So we're really, really excited to have her. Dr. Stockton, the floor is yours. Thank you.
Okay, thank you, Gage. Can you hear me okay? Is my microphone working okay? Because I've had situations where that's not been the case. So right now, I'm not in clinical practice. I'm really kind of in an educational capacity. Well, and come on, let's go. Yay. So I'm working for the Midwest AIDS Training and Education Center at the office here at the University of Cincinnati. It's a federally funded project. Primarily right now, I am a project consultant, and a lot of what I do is working on educational activities for healthcare professionals around the Ending the HIV Epidemic initiative. These are my disclosures here. And these are the 4 learning objectives for the presentation. We're going to start out by just talking about the current HIV landscape in the United States, because there are a lot of people, since we don't hear a lot about HIV so much anymore, there are a lot of people when I say, oh, well, I do HIV work, and they're like, is that really even still a problem? And unfortunately, yeah, it is. So it was last year marked 40 years since the first report in MMWR about strange conditions that were appearing in men who have sex with men living out on the West Coast. And over the years, we've really made some considerable strides in diagnosis, in treatment. And now we're in a situation where half of the people in the United States living with HIV are over age 50. Some of them because they've been diagnosed since, in their later years, but many of them because they have survived. Which we didn't really think many of them would when they were first diagnosed. I've been in HIV care since 1991, so I remember some of the really difficult years. Well, so we've definitely improved the risk of people eventually becoming HIV infected. The numbers are lower, and those who acquire it and then die because of it are lower, but we still see a lot of disparities by sex, by race and ethnicity, and by risk group. And you can see here by the statistics that communities of color still remain disproportionately represented among those who are living with HIV disease. Men who have sex with men are 79 times more likely to acquire HIV than those who are heterosexual. And people who inject drugs, that's abbreviated there, PWID, they are 13 times as likely as those whose risk behavior might be heterosexual contact. And you can see in the bar graph off to the side that in some jurisdictions, in some communities, African-American men who have sex with men have like a 50-50 chance of acquiring HIV infection sometime during their life. So in 2019, in January 2019, during the State of the Union address, then President Trump announced the Ending the HIV Epidemic Initiative, or it's abbreviated EAG. And it was really a pretty good plan as it was designed. The goal was to reduce the number of new HIV infections by 75% over the first 5 years, and then up to 90% or greater by a 10-year period of time. And you may remember, so this was the beginning of 2019, and we know that toward the end of 2019, we kind of got distracted by this other pesky little virus known as SARS-CoV-2, and you've probably heard of it. Anyway, it really kind of derailed everything. We were just getting ready. The 2019 was sort of like the gear up year, and then we were supposed to really start rolling things out in 2020. And not only did that not happen, but because of a lot of things that happened with the lockdown, many HIV experts suspect that we have kind of lost some ground there. Typically, we would see around 38,000 new cases of HIV. But during the lockdowns, we had community test sites that were closed. We had offices that were closed. We know that a lot of people living with HIV have pre-existing mental health conditions, depression, anxiety, and the social isolation we suspect caused a number of them to cope by maybe using more drugs and alcohol, by resuming some sexual behaviors that were not as safe. And we suspect that we're ultimately going to see that we have lost ground there. So now that we've got less problem with SARS-CoV-2, we're hoping that we can sort of pick up and regain some of our momentum with ending the HIV epidemic. So these are the 4 pillars that were identified: diagnosing people, so increasing our testing, getting them into treatment, linking them to care, getting them on meds so that they're virally suppressed and therefore not likely to or not able to be transmitting HIV quite as easily. Prevention using both HIV PrEP, pre-exposure prophylaxis, and syringe service programs, as well as responding quickly to HIV outbreaks. And that particular role is primarily one that resides with the public health community. So we know where HIV tends to occur more frequently. And so this map, you can see that, that Ohio is in the top quarter, but a lot of the HIV diseases on the East Coast, on the West Coast, and on the Southeast. And this information was used in the planning for the EHE initiative. It allowed us to identify 57 priority jurisdictions. And there are 48 counties and 2 cities, San Juan, Puerto Rico, and Washington, D.C., where between 2016 and 2018, over 50% of all new HIV diagnoses occurred. Then you can see and those are on the map here in dark blue. The light blue states are the 7 states that have higher than average HIV cases in rural areas. So, and you can see that this kind of reflects the previous map. But one thing that I think it's really important, sometimes I think people think because we're in Ohio and it tends to be conservative in many ways, that we don't have issues with HIV risk. Well, you'll see that the entire Midwest, most of those states have like no hotspot counties or maybe 1 hotspot county. And here we are in Ohio with 3. So we in Ohio, we've got our work cut out for us. Not to mention the fact that here in Hamilton County, we've got a hotspot state just south of us. And we all know that viruses are no respecter of state lines and not dissuaded at all by rivers and county lines or whatever. So we've got a lot of HIV going on in our state, particularly here in Hamilton County, and so we are among the priority jurisdictions for the HIV epidemic. Part of the responsibilities for those priority jurisdictions was to come up with a local EHE plan, where they gathered together local stakeholders and identified issues that we really need to address. And this slide here shows a portion of what the Hamilton County, Ohio plan includes: integrating prevention into primary care by encouraging primary care, family medicine, nurse practitioners, internal medicine, other healthcare professionals who deliver prevention services to regularly screen for and talk about HIV. And one of the sub activities underneath that was to increase the PrEP provider network. So one of the things that oftentimes people wonder is like, well, so why all these like primary care? Why, where is ID in all this? Isn't it their job? Well, I was kind of surprised when I saw this map. It's included in an article that was written by Rochelle Walensky before she became director of the CDC. Title of the article is "Where's the ID in COVID?" And what Dr. Walensky and her co-authors did was they came up with this map that kind of showed where are the ID providers across the country. There is less than 2 per 100,000 population on average. And you can see here on this map, the blue counties are those that have higher than national average ID physician present. Those that are red are below, and those that are white have no ID physician in the county. So if you think about the fact that right now we've got 1.2 million people in the United States living with HIV, we have COVID. ID people are also trying to deal with hepatitis C overflow from GI. They're trying to deal with the infectious disease complications of injecting drug use. And they're also still trying to deal with all of the garden variety bugs that typically are referred to ID specialists. And so it isn't that they don't see value or a need or importance in prevention. It's just that they cannot spread their day one more direction. You add to that the fact that those of us who joined the HIV, the infectious disease workforce earlier in the HIV epidemic are now aging and preparing to retire, and we're not really seeing an influx of interest from other from the up and coming folks within healthcare delivery. So it's really not possible for us to be doing the prevention stuff as well as all the treatment stuff, and actually primary care and particularly nursing. That is where illness prevention and wellness promotion really are concentrated. That's where people with the skills and the interests are. And so we're hoping that our colleagues in primary care will recognize the value that they bring to helping us reach more people. So describing the relationship that exists between STIs and the risk of HIV acquisition. So we first became aware of this like in 2009, where this report came out from San Francisco, where they noticed an increase in the number of rectal gonorrhea infections in people who were acutely infected with HIV, and they raised the question. So is there a connection between rectal GC and HIV acquisition? So they looked a little more closely at their patient population, and they found that among the men who have sex with men who had 2 or more rectal bacterial STIs in the prior 2 years, the incidence of HIV was 15%. They looked also at syphilis, and those who had been diagnosed with syphilis in the prior 2 years were 4 times as likely to acquire HIV. And they found that 35% of all those diagnosed at San Francisco City Clinic 35% had rectal, gonorrhea, or chlamydia prior to their diagnosis of HIV infection. There was then a subsequent study that was done in Atlanta, and what they found in that study was that MSM diagnosed with a rectal STI as part of this study were more than 2.5 times as likely to acquire HIV as those who were not diagnosed with a rectal STI. And they postulated that nearly 15% of HIV infections in their population may have been prevented had those rectal STIs not occurred. So looking at high-risk behavior, is it a marker for high-risk behavior, or is it does it contribute to HIV infection? Well, it's actually both. So we know that when you acquire an STI, there is a disruption of skin and mucous membrane integrity. And sometimes that's at the microscopic level, but it's still a break in our first line of defense. And what happens in response is that mucosal lymphocytes will be exposed, keeping in mind the fact that lymphocytes are the target cells for HIV and are kind of hijacked by the virus and converted into HIV factories. The second thing is that you have the initiation of the inflammatory response. So you've got increased blood flow and increased T cell activation, once again, really contributing to the ease of acquiring that infection and having it getting into the cells where it's most likely to take hold and promote reproduction. And if you look at the increase of STIs here in the United States, it's really pretty breathtaking. And this is the 2019 data. I've seen the 2020 data, and it's not looking any better. In fact, it's looking worse. So we have to remember that all of these infections are going on out there, although the data that I just reported was on men who have sex with men. Certainly, people who are heterosexual, their risks would be the same if they had an STI and then became exposed to HIV. So talking about now the importance of getting that sexual history and doing a comprehensive STI screening and people where we're trying to do HIV prevention. Now, this booklet here, it's a little dated date-wise, but the content is still very much applicable. It's one of the best resources I think I have ever seen and for people who are trying to improve their skills and understanding of how to effectively do an HIV risk assessment. Now, I will tell you that when we talk to people about doing a risk assessment, that probably the better way to frame it for them, for a consumer, is to talk about it as a sexual health assessment. If we talk about an HIV risk assessment, it kind of implies to the patient that we want to know from them, that what bad things are they doing, and there's enough shame associated with HIV. You don't want to inadvertently add to it. So if you say sexual health assessment as opposed to an HIV risk assessment, they hear it differently, and they're going to probably be more comfortable disclosing to you some important pieces of information that you as a healthcare professional will need to help them avoid becoming HIV infected down the road. So the key message that you want them to take out of your visit with them is that you are a safe person and that your office is a safe place to have discussions about sensitive issues that are difficult and sometimes painful to talk about. I can tell you in my own practice as an HIV clinical nurse specialist, I encountered a number of people who had issues in their past that they really wanted to talk about, needed to talk about, and just didn't know where they could go with that. They're not going to come into your office assuming that you're a safe person or that you need to know or that you want to know. But of course, it's an important health aspect. So of course, we as healthcare professionals, we want to know, we need to know, and we want to be able to use that information to help them optimize their own health situation. So when you're going to be doing a sexual health assessment, the important thing is to not pull the rug out from under them. You just let them know where you're going with the conversation so that they're prepared for that change. Many of them, they are not ever going to have had a sexual health assessment done. And so they may be a little taken aback by the fact that you will even bring it up. But you normalize it. You let them know that you're not trying to pry, you're not trying to get in their business. You just want to be thorough in your healthcare delivery, because sexual health is important, and it's just another part of someone's overall healthcare. So if you look at some of the best ways that people recommend doing a sexual health assessment, they've got the 5 Ps: partners, practices, prior STIs, pregnancy planning, and protection from STIs. So this is such a common approach that the CDC actually includes it in their guidelines for STI diagnosis and treatment. The thing is that people in primary care, well, not just primary care, all of us, we're busy. And so you put all these questions in front of people and they're like, no, I can't do that. So what's been recommended is if you really cannot work in a complete sexual health history, if you can just focus on 3 questions. Sorry about that, push the wrong button. Do you have sex with men, women, or both? When you're intimate, are your partners male, female, or both? Come up with your own way of asking that question so that you're comfortable asking it. If you're not comfortable asking it, it's not likely your patient's going to be comfortable answering it. So the next question is, in order to understand how best to provide sexual health care for you, I need to know what kind of practices you engage in. Do you engage in oral sex, anal sex, vaginal sex? And the third thing is, have you ever had an STI? We've already talked about the important role that STIs play in increasing the risk of acquiring HIV if a person's exposed. So when we talk about a comprehensive STI testing, what is it that we're talking about? Well, basically, it's HIV, syphilis, gonorrhea, and chlamydia at all potentially exposed sites. Now, it may sound like, well, yes, of course, HIV is part of an STI workup, but it would surprise you how many times an STI workup does not include an HIV test. So these are the recommendations from the CDC that came out in 2006, and we are not even close to having incorporated them routinely into our care. The one here I'm going to highlight first is HIV screening during prenatal workup. And you would think, well, of course, that makes sense. You want to make sure mom's HIV positive. We know that, so we can take steps to make sure that she doesn't transmit HIV to her infant. But the studies that have been done have shown that only about 70% of women who are pregnant get an STI, an HIV test done prior to going into labor. Some of that is because some women don't go into prenatal care, but there are still a significant number of OB providers that don't do it because they don't think that their patients need it. Well, the problem is that with women, many of them acquire HIV not necessarily because of a risk behavior that they themselves engage in, but because of a risk behavior that their partner engages in, and they may or may not know that. The other thing that recently I learned is an issue is the need for doing repeat screening in 3rd trimester in areas with high HIV rates. So those 48 counties, 2 cities, 7 states. Those are probably places where we should be routinely checking our moms during the 3rd trimester, just to make sure that they haven't acquired HIV during their pregnancy. And the 3rd one, and this also should make a heck of a lot of sense, is that people who are at risk should be screened at least once a year. Nobody is probably can argue with that, but the problem is, do you know if they're at risk? If you're not asking, how do you know? Do you know just because you look at them and they don't look like they're at risk? Well, of course not. But although we can say we know you cannot look at someone and tell their HIV status, that's only verbal. And, you know, people say actions speak louder than words. So what is your practice saying? What is your practice saying about what you believe? Does your practice say, I can tell just by looking? Or are you actually incorporating routine HIV testing into the care that you give your patients? So, well, why is it that people are that are having problems with actually offering testing if since 2006 we've had these guidelines? Well, there's a number of reasons. One is that, you know, providers will often expect the patient to ask, and then we'll do an HIV test if they ask for one. Well, I mean, where else do we put the burden of a routine screening on the patient? I mean, think about it. If we if we only referred people for colonoscopies, screening colonoscopies, when they asked for one, how many screening colonoscopies would we do? Probably not many. I mean, that is our responsibility to bring to the attention of the people who entrust their care to us. This is something that's important. And I really think, you know, that since you've not had an HIV test, I think we should get one. Unsure of how to bring up the topic of HIV testing. Well, the truth of the matter is, I mean, there's a lot of things that we didn't know how to do as we progressed in our career. We didn't know how to do a blood pressure. We didn't know how to do chest auscultation. We didn't know how to do a lot of things, but we understood that these things were important in order for us to do our jobs properly and well. And so we found out, where do I need to go to get the training that I need in order to be proficient in this particular skill? And this is no different. Don't know how to handle positive results. Well, we all know that giving bad news is a very difficult but very real component of being in healthcare, being a healthcare professional. And it's far more likely that you would have to talk to someone about a suspicious lesion on a mammogram than a positive HIV test result. But that does not dissuade us at all from speaking to women about the importance of having screening mammography done, just because we're afraid we may have to tell them that they've got a suspicious lesion. So it should not be any different from getting HIV testing then either. The patient might refuse. Well, you know what, that is their right. And we know now with COVID that there are a lot of people, 30% of the adult population here in the United States are refusing to get a COVID vaccine. That doesn't mean we don't present them with the facts about why it is important, and then respect their right to make a decision, even if that decision conflicts with what our recommendations are. No time and competing priorities. And certainly that is an issue, it is a concern, and that's why just trying to work in those 3 questions would at least reduce the time commitment that the professionals might need to invest in doing a sexual health history and HIV testing. So going on with the other steps in the STI screening, doing syphilis testing, which is through a blood sample. What doesn't happen quite as often is 3-site testing for gonorrhea and chlamydia. That would be genitourinary, oropharyngeal, and anorectal. And in some studies, it shows that if you're just doing urine screening, that you can miss up to 70% of the GC and chlamydia cases. It's important too to remember that Women engage in receptive anal sex as well. And some studies show that up to 35% have at one time or are now engaging in anal sex. And it's important that you ask about that. They're not going to tell you. They may be embarrassed about bringing it up. They may be afraid that you're going to shame them. So, and one of the easiest ways to bring it up is to normalize it and just say, there are a number of women who enjoy anal sex. Is that something that you and your partner enjoy doing? And we'd also already talked about the fact that anal rectal STIs significantly increase the risk of HIV acquisition if we're exposed. So the way that you do the GC and chlamydia, the genitourinary testing, of course, can be done by urine sample, and the oropharyngeal and anal rectal by swabs. The swabs can be self-collected. There have been studies that have shown that they're just as accurate as if they're done by a clinician. So I'm just going to share with you some of the data that I collected while I was running a little PrEP practice. And I'm sorry that, at least on my screen, part of my slide is blocked out there. So I had 75 people that I followed for PrEP. You can see the age breakdown. You can see they were primarily white, non-Hispanic. There were 5 people who discontinued for one reason or another. Most of them kept all their visits. I only included in the evaluation those who had at least one follow-up visit after their initial. And as part of their test, part of their every 3-month checkup, I did comprehensive STI exams. So you can see that of my 57 patients that I included in this evaluation, there were 43 STIs that occurred in 18 patients. 9 of those STI episodes were syphilis, and 34 of them were GC and chlamydia. But you will notice that of that 34, only 3 of them were picked up in urine, and the other 31 were picked up on swabs. And 45% of the cases were bacterial STIs in the anal rectal area. Believe me, just keeping track of what I was seeing as these results were coming through really made a believer out of me regarding the importance of being conscientious and comprehensive in my STI checks for my peeps. So there's a lot of misunderstanding about the significance of the STIs in among those who are on PrEP. Many of them are men who have sex with men, and a number of people believe that that we're seeing the increased rates of STIs because of what's called risk compensation or behavioral disinhibition. And this is an assumption that that people go on PrEP because they kind of want permission or license to just have sex with anybody and everybody, however they want. Well, that has not been supported by the research. There have been a number of studies that have been done that show that this really doesn't happen. And I can tell you, although I didn't track it, I did inquire when I was seeing my patients about the sexual activities that people were engaging in, and they really did not change from the time that I did their initial PrEP entry visit and then followed them on through care. And when I've talked to other nurse practitioners who also do PrEP, they said the same thing. So that's really not an issue. What we believe is that, I mean, we're doing STI screening on these folks like every 3 months. I mean, where else do you see that being done? So of course, it's more likely you're going to be picking them up simply because you're doing them and you're doing them on a comprehensive basis. And we've also mentioned the fact that there's this overall increase in STIs nationwide. So the bottom line here, though, is that a concern about STIs and an increase in STIs among people on PrEP. That should not be a reason to refuse to prescribe PrEP. And unfortunately, that's happened. And it's very shaming to the people who experience that they're coming to a healthcare professional. They're saying, listen, I know I'm at risk for HIV infection, and I really would like to be on PrEP. And the answer they get is, I'm really more concerned about you getting syphilis than I am about you getting HIV. And so please, if that is a concern that you have, keep in mind the fact that if you keep them engaged in care, and you have this concern about their high-risk sexual behavior, keeping them in care and helping them to understand the importance for their own health, safety, and well-being of perhaps considering how they might modify the behaviors. That is really how you're going to be able to impact them, and not by refusing them PrEP, which is something that they recognize that they need for their own health and well-being. So finally, identifying an evidence-based approach to implementing PrEP. So PrEP is defined as using an antiretroviral or ARV in an HIV uninfected individual before a potential exposure. It's always presented as a comprehensive package. This isn't just the pill and that's it. It's the medication plus condoms, plus the comprehensive STI checks and that risk reduction counseling. There are multiple options now available, both oral and injectable, and there are a number of them already in development. This is an evidence-based practice, and it is a critical part of the EHE initiative. So we know not only are there 1.2 million people living with HIV in the United States, but there's also 1.2 million people in America who have conditions that are an indication for PrEP. Unfortunately, only about less than 25% have ever been prescribed PrEP. So these are the guidelines that came out in this past December that really go over step by step the way that a clinician would initiate a PrEP service within their practice. So one of the things that they include in these guidelines is this sort of a schematic that shows you step by step how you help people get through the PrEP process. And two things I want to point out here is the references to acute HIV infection, that you check for HIV and you ask for about signs and symptoms of acute HIV infection at baseline and then at every follow-up visit. Because you want to make sure, even if a person is on PrEP, there have been cases where people have acquired HIV infection. They are rare, but it does happen. And you want to make sure, certainly, that if a person is HIV infected, you identify that prior to getting them started on PrEP. So what is primary HIV infection or acute HIV infection? This is that early interval between when the person is exposed and infected and the time that they actually start producing antibody. Keep in mind, the antibody response is the last part of our immune system to kick in. So it takes several weeks before you actually have met measurable levels of antibody, even though the virus is floating around. The viral load at that point in time is very high. It can be as high as greater than 10 million copies per cc of blood. And people will report symptoms within about 2 to 4 weeks of having been infected. So these are the symptoms that people will report during that acute phase of HIV infection. And I want you to just look over this list and think about, if a patient presented to you and they reported these symptoms, if there's any one of those symptoms that would kind of stand out to you as, gee, I should probably ask this person about getting an HIV test. Well, there isn't one key that's going to be a giveaway. these are symptoms of an acute viral illness, and it doesn't make any difference if it's flu or HIV or mono or even COVID. So it's really important that you keep in mind the fact that when you're seeing somebody with symptoms of an acute viral illness, you need to have HIV as part of your differential diagnosis. It has to be on your radar screen. Otherwise, you're going to be looking right at it and you're not going to see it. It happens more often than you like to think. So, so this diagram here just kind of shows what's going on in the patient from the time that they get infected at point time 0 over there. You can see that it takes about 12 days before they start to become viremic. And up until that time, you can do whatever test you want. Chances are you're going to come up with a negative result simply because the person's not viremic. You're not going to be able to detect the presence of the virus, and you're certainly not going to be able to detect the presence of antibody. So you get to about day 12, and remember, people were talking about, those symptoms start occurring within 2 to 4 weeks. Well, the reason that it starts in about 2 weeks is because that's when people start becoming viremic, and you can see that by the green line, that's when the virus can actually, the presence of the virus can actually be measured in the blood. It'll take about another 4 days before the virus particle, that P24 antigen, is detectable. And when you do an HIV test, when you're doing HIV screening, that is what the test is going to be looking for. It's going to be looking for that antigen. So if you do an HIV test prior to like day 15, chances are you're going to get a negative, false negative, because what the test is looking for isn't measurable yet. The newest 4th generation HIV tests look for that antigen, and that's the ones that the tests that are most likely being done now. But you will notice that antibody doesn't kick in until about 3 weeks after the person is initially infected. So if you have a person who comes in with symptoms of an acute viral illness, by their history, you have a concern that they may be acutely infected with HIV, go ahead and do the test. But you may also want to go ahead and get an HIV RNA or HIV viral load at that same time. Save yourself a few hours or a few days, because what you may see is this. This is typically what an indeterminate test or a test looks like when a person is seroconverting, that you'll see that the antigen was detected, but the antibody was not. And typically what your lab will do is then reflex to an HIV RNA or a viral load to confirm whether or not this is a false positive. You may see a false positive in people who are pregnant or people with autoimmune disorders, where their tests are just going to be a little crazy. So with PrEP, there are 3 agents that are now FDA approved for use. There's 2 oral agents that are tenofovir based, TDF-FTC, tenofovir disulfoxyl fumarate, and TAF, tenofovir alafenamide, along with emtricitabine, commercially available as either Truvada, which is also available as a generic, and Descovy. Also back in December, in addition to the new guidelines coming out, cabotegravir, an injectable that can be given every 8 weeks, also now available. And the key here is people have to be adherent to whichever product they're on, or chances are they're going to end up with a breakthrough infection. There's also an off-label use for TDF-FTC, the Truvada product, where people who are not very sexually active, want to be on PrEP, but don't feel like they really need it every day. It's off-label, not because there's no evidence that it works. It's just that now the Truvada, the only agent that's been tested with that, it's now available as a generic, and so the manufacturer, Gilead, is not going to go through the work and the money of submitting an FDA application. But it is available as an off-label use, and if if you want some additional information about it, you can go to this website, and gives really some very good directives on how to properly take it. Risk reduction counseling, we go back to the booklet I mentioned earlier. Again, a very, very good, very nicely written resource available online. You just download it. So in closing my presentation, I want to talk with you. I just want to give you a story about a presentation I heard back in the mid-1990s. It was given by a gentleman by the name of Bernard Young. Bernie was a supervisor, African-American gentleman, supervisor with Cincinnati Health Department, great guy. And he was giving this talk. And he said that oftentimes, people would see that abbreviation AIDS, and immediately the first thing that would pop into their head was AIDS, acquired immune deficiency syndrome. And Bernie decided that he was going to change his thinking about that rather than seeing it, AIDS, as a healthcare challenge to someone living in the community, he was going to see it as a personal challenge. He was going to ask himself, am I doing something? It's been so many years now, but I've never forgotten what it was that Bernie said that night. And in fact, the interesting thing is that even though we are decades later, we still should be asking ourselves that very same question. And there are so many things now that we can be doing. We can be doing those routine HIV screenings that CDC told us about back in 2006. We can be doing that sexual health history and helping people to understand how to get themselves in a healthier place. We can be doing comprehensive STI testing and making sure that if people have STIs, we're identifying them and getting them treated so that they're not putting themselves at increased risk of acquiring HIV should they be exposed. We can do risk reduction counseling, and we can be offering them PrEP. Now, we realize that that some of these things you may feel skilled in doing and others you don't. Well, MATEC, the group that I work with, this is one of my projects, is developing this online training. We developed it using a micro-learning approach. There are 6 modules with between 2 and 4 lessons in each one. Each lesson is 10 minutes, doesn't take that long. You don't have to take all the modules. You don't even have to do all the lessons. If you want the CE credits, you have to complete the module. And you don't even have to take the modules in a set sequence. This is what the program looks like. We have the PrEP basics done, and we are getting ready to start working on the PrEP challenges. I would really encourage you to take a look at this, and if there are components of the Am I Doing Something challenge that you see here that you think you might need some help getting some more information about, please access it. And if you do, let us know how you feel about that micro-learning approach. Did it really help you? Is it a better learning mechanism? And give us some of your feedback so that as we're preparing the part 2, the PrEP challenges, we'll be better equipped to do that as we get started. There are a lot of other resources that the Midwest AIDS Training and Education Center, MATEC, and the AIDS Education and Training Center has available. All of these are free. Most of them have CE contact with them. So please feel free to check out any of these other resources with AATC. This is how you can contact our local AETC office at University of Cincinnati, either by phone or here's my email address. And so in closing, I just hope that you have learned something about a way that you can contribute to the Ending the HIV Epidemic initiative, because we've got the tools available. However, if we don't use them, we're not going to be as successful as we might otherwise be. So one last thing I need to just mention is that Gage and I are working together. I mean, he wants to make sure that the University of Cincinnati alumni office gets credit for this presentation. And I need to make sure that my office is able to report to our funding source, HRSA, that we are using your tax dollars wisely and well. So the evaluation that we'll be asking you to do for CE credit will go through MATEC, but then the CE credit will be coming for you through Gage and the College of Nursing. So if anybody has any questions, we'd be happy to take those now. Oh, and there's my sweet friend, Yolanda. So Yolanda, I have to tell you a story about Yolanda. So I was working for Yolanda with the AETC. She was my boss. And we were working together right when PrEP came out. And I was such a PrEP skeptic. I was. And I even did a presentation on why you should be asking questions about whether or not PrEP is the way to go. And so when Yolanda found out that I was going to be doing a PrEP clinic in one of my previous clinical positions, she almost like couldn't believe it, that the PrEP skeptic had actually turned into a PrEP champion. So it's delightful to see your little photograph there, your little thumbnail, Yolanda.
Jan, thanks for that story. You have always been open to learning or doing whatever is necessary for your patients in HIV care. So even though it was surprising, it shouldn't have been, because I knew that you would do anything for your patients to improve their life and their care.
Thank you, Yolanda. Thank you. So does anyone else have any other questions, any comments, anything that they would like to share?
Did you see that chat?
So from New Mexico. Yeah, you can check with your AIDS Education and Training Center out there. And actually, the New Mexico AETC has really taken a leadership role in consumer education. When I was in clinical practice, I can't tell you how many times I relied on some of the educational products from the New Mexico AETC, particularly around treatment. And I appreciate the positive feedback that I'm seeing from others attending. For those of you who would like more information about the ending the HIV epidemic and what might be going on in your respective state or community, you can just do an online search for ending the HIV epidemic. You can go to the CDC, go to cdc.gov. They've got a lot of information there. And also the HRSA website, they have a lot of information as well, and you can find out what is going on in your respective community to try to end the epidemic.
Cool. Well, doesn't sound like there's any other questions. Again, Jan, thank you so much. I think obviously for everyone who was just on the call, you're an expert in this topic, and we could have a better person present to us. So thank you so much.
Thank you, Gage. I appreciate the opportunity to be a part of this. And if you have questions, if questions come up later, please feel free to contact me at the MATEC office here at the University of Cincinnati. Be happy to help you.